Hi everybody, this is Dr. K from Holistic Minds. I'm so happy to be introducing Dr. Soroush Zaghi to you. This man has literally changed my perspective of pediatric health, especially when it comes to children with behavioral issues, sensory problems, a host of other things. And I mean, I'm really humbled to have learned as much as I have from you, and you have literally just completely blown my mind, because I thought I knew a lot, but in interacting with you and learning from you, I've realized how little I knew about airway, sleep, and how that impacts so many things. Now, Dr. Zaghi is no slouch. He graduated from Harvard Medical School, went to UCLA for his ear, nose, throat training, and then if that wasn't enough, he went to Stanford to do specialty training in a fellowship in sleep. So I'm so happy to be introducing him.
Yeah, well, thank you so much for coming here and for all the work that you do as such an outstanding and open-minded pediatrician. It really takes a lot of heart and desire to work with the kids and the population that you do. It could be so easy to just look at the kids that come into you and say, this is normal, it's normal to not have attention, it's normal to breathe through your mouth, it's normal not to sleep well, you'll grow out of it. But I'm really pleased and impressed that you're one of the doctors that goes to the edges of the earth to find out the answers to help your kids, and I really thank you just for your open-mindedness and willingness to listen and to learn and to collaborate together to really help these kids live a better life.
Thank you. I mean, I think we're both in it for the same reason,
Yeah.
right? To make the world a better place for these kids and really to give them the ability to achieve their full potential.
Absolutely, because when you look at some of these cases that we reviewed together, it's just heartbreaking. It's just heartbreaking, and just to take a look at what it's like for them. You know, me myself as a sleep physician, my job is to make sure that that kids can sleep comfortably throughout the night without gasping, without snoring, without choking. And one thing that I often ask parents to do is just to take a 2-minute video. Mm-hmm. And some of these videos that parents bring in, it just wrenches my heart to see the child struggling for air. And if they can't breathe, they can't sleep, and if they can't sleep, they can't function. And if they're not functioning well throughout the day, like we talked about, it can affect their nutrition, their overall health, increased levels of inflammatory hormones that kind of translates into the kind of problems that you see in your clinic.
Yeah, and you know, in a way, people would think like we're stating the obvious, right? People would think like, well, yeah, if you can't sleep, everything falls apart. But it blows my mind how little attention we pay to this. Because, like, you know, the catastrophes where the kids are choking and, you know, those are obvious. And the reason why I want to come and speak with you is I've seen other ENTs miss these problems. I've been guilty of missing them. I've had other pediatricians. So there's so little awareness. Like, even though it's obvious, I think there's so little awareness when it comes to sleep quality and airway and oxygenation while we sleep that I think this conversation is really paramount. And
Absolutely.
People really need to understand all of the subtleties and how all of this comes together, because it's so easy to say, oh, well, my kid's sleeping, you know, they just toss and turn all the time. Yeah, every now and then they just come, you know, gag, and they think that that's okay. But when the kid is losing their mind, when they're about to fail out of school, when they're showing aggression, they don't realize that that momentary pause, that tossing and turning in sleep could be the entire reason.
Absolutely.
And,
absolutely.
You know, the funny thing is, as a holistic pediatrician, I'm all about doing all of these natural remedies, but in seeing the work that you've done, you know, parents are shocked, where I'm like, no, if he says you got to do surgery, you got to do surgery. And it's mind-boggling to me to see some of the changes that I've seen, where kids that had X, Y, and Z problems, ADHD, anxiety, OCD, I mean, they had a laundry list of issues. They get their sleep disorder addressed, surgery or not, and all of a sudden they're great.
It's amazing. It's amazing, and we've seen the same things, and that's what kind of perpetuates us and gives us the fuel and the fire to go after helping these kids. Because, like you said, it's not just about sleeping, right? It's about the quality of the sleep. because there are different stages of sleeping, and a lot of times what these kids are suffering is just a predominance of light sleep, the restless stage 2 sleep, and they're not getting into that stage 3 sleep where they're releasing growth hormone and suppressing the release of cortisol. And sometimes they don't even reach REM sleep. And you need that deep REM sleep and the deep stage 3 sleep in order to not only heal your body, but also to let your mind refresh and to regulate mood processing and emotional regulation and attention and concentration. So I think that's really where the disconnect comes, because it's not just about sleeping, but it's about achieving deep and quality sleep.
Quality sleep. Now, you touched on some really important points that I think parents should really be aware of. So first of all, parasympathetic state. So that's when we go into the deep rest and relaxation state. When we go into the stage 3 sleep, the stage 4 sleep, how does that influence the parasympathetic state for the course of the day?
Absolutely. And so basically your body has a balance between sympathetic and parasympathetic nervous system. And you really have to have a balance of the two. The sympathetic nervous system is mainly involved in like a fight or flight response, something dangerous, something immediate that you need to upregulate your blood pressure and take care of an immediate issue. Your parasympathetic nervous system is more of the rest and digest, and it's more thinking of long-term issues. Okay? So you need to have a balance. You need to have a balance between the acute, the immediate threats, and you need to have a balance between the long-term. And so what we see a lot of times in these kids is dysfunction of sympathetic versus parasympathetic coherence. So that when you're sleeping is a time where you should be relaxing, refreshing, calming down, getting ready for the next day's events. But in these kids with sleep issues, they're not able to focus on tomorrow or the next day. Their body can't afford those resources for helping them grow and mature on a physical and emotional and mental level, because the body's focused on just getting through the night. And when they're just trying to get through the night,
they're surviving.
They're just trying to survive that night. And when they're trying to survive that night, that's where the sympathetic comes up. That's where the cortisol comes up. And it's these changes in the inflammatory marker, these changes that cause hormonal changes that make more inflammation in the body, that change the kind of foods you prefer, the amount of energy you have for diet and attention. If you're struggling to breathe at night, it doesn't matter. You don't have the attention necessary to do well in school. You're trying to survive that night. You don't have the resources to process memory and to form those neuroplasticity channels. Your mind is saying, how can I position myself and put myself in a way that I can just breathe?
Just survive.
Just to survive.
Just survive.
Yeah. So that's what we're seeing in this, because they're just trying to get by. And when they're trying to get by, you have increased sympathetic, their adrenal glands are going off, and that's why they're so jittery, because the body's just up-regulated.
Yeah.
And so kids are different than adults, because adults, when they don't sleep, they get tired, they get fatigued, they fall asleep. Kids aren't like that yet, because they have a very robust compensation network. And so their adrenal glands are pumping out all these hormones to keep them going until that burns out.
Yeah.
And then you get the fatigue and the sleepiness and, and the depression and anxiety and issues like that.
That's a really, this is a really powerful point, people. You really need to be understanding this, because I can't tell you how many of the kids that I test for, because I actually check cortisol levels in the kids. And I'd say about 60% of the population of the kids that I see are in that early stage of high cortisol, and then there's another 30-40% where their adrenal glands have kind of pooped out, and those are the kids that are the real messes. So they have this weird anxiety, but yet they're tired, they're kind of dragging themselves through the day, and it's just awful. And you know, this point of the adrenal glands being messed up in a way, so the entire HPA axis, the control axis that it regulates the adrenal glands, regulates all hormones really, is so thrown off when we don't sleep well.
Absolutely. Absolutely. Like we talked about, you need to get into that stage 3 deep sleep to release the growth hormone and suppress that HPA axis. And if you're not getting into the sleep, then you're going to have upregulation of all those issues just to survive that night.
And let's touch on this, because what I find so often is, when kids are just tossing and turning all the time, they're like every 2 minutes, especially like 2-year-olds I get, they move. But in the older children, 5, 6, 7, 8 years old, if they're constantly tossing and turning in their sleep, how normal is that?
So if they're tossing and turning in their sleep, that tells you that they're in a state of light sleep. Because during deep sleep, your body's relaxing more and more, and you don't move at all. You don't move very much. And during REM sleep, actually your body is paralyzed. You can't move during REM sleep. So if they're tossing and turning throughout the night, what that's telling me is that they're mainly in a state of light sleep, and they're not getting deep sleep, and they're not getting REM sleep. And so that's where the real problem is. So
in a way, if a kid tosses and turns all night, they have disordered sleeping.
They have disordered sleeping because they're not getting the very, very deep sleep.
Interesting. And people, you need to be looking at this and paying attention.
Yeah.
Now, you touched on something about inflammation, and I think that's actually a really valuable point for us to expand on, because another thing that I see in this type, so the children with severe behavioral problems, and we see it also a lot in the autism community, that these kids have a lot of inflammatory markers. And one of the things that I have to do is work with families to actually bring the inflammation down through the diet. But I don't think a lot of people are aware that inflammation actually causes or triggers elevations in C-reactive protein and other inflammatory markers. So can you share with us a little bit?
Yeah, absolutely. It's kind of like a chicken or the egg situation. What came first? But not sleeping elevates your C-reactive protein, your cortisol levels, makes it more pro-inflammatory. That inflammation actually has an effect on the soft tissues in your neck and inside your nose, like your tonsils and your turbinates. The response is for them to swell up. And when they swell up, it further blocks the breathing. And it further blocks the breathing. It's even more difficult to fall asleep, and you get more inflammation. And then it also changes your diet preference, what kind of foods you gravitate towards. Because when you're in that fight or flight response mode, your body is telling you that you need to get fatty foods that are going to help you sustain that emergency event. You're not going to. You're going to be more attracted to the high sugar and the carbs and the fats, because that's what you need to get through. And it's not going to. And it's going to dissuade you from going towards the more nutritious foods that you need to heal and grow your body.
And that just further promotes inflammation.
And then you have more inflammation, right? And then the bacteria in your gut change as a result of that. As the food that you eat, the bacteria becomes foods that are more favorable towards inflammatory foods,
which then worsens everything.
Which was everything. So it's just the cycle.
So everything is connected. Everything is connected.
It changes the way that your genes are expressed. These inflammatory markers. So there's something called epigenetics, which I'm sure you're aware of. And so everyone has a certain number of genes, but some genes get turned off or turned on based on your environment. And so if you're in an environment of pro-inflammation, then your body reacts accordingly just to try to survive, because your body doesn't know that it's here in an environment where you're safe, where you're not physically threatened, where there isn't food scarcity. It doesn't know the difference. It was evolved to be that way for a state of, there's a drought, there's not enough food, you have danger from your local environment, and so when it sees these threats, it produces changes on a physiological level that are no longer adaptive to address that threat.
Got it. And this is so valuable, and thank you for sharing that.
Thank you very much.
I think this is the part that's missing from the conversation. People are just like, it drives me crazy, because there are some holistic practitioners who are like, well, we'll just treat the gut and that fixes everything else. And part of the point that I have to drive to our families is, well, if your child has been in a perpetual stress response since they were 2 years old because they were obstructing their airway or not having proper sleep hygiene, that could change the gut microbiome. So this person is looking at the gut bacteria thinking, well, we'll just change the gut bacteria and fix it. No, you've got to address the airway.
Right.
And I think that this interconnection and really helping people see how everything is tied together and everything connected can affect everything, and everything can make everything worse. And the sad thing is, in most of these kids, what I see is there's been one hit, there's been another hit, there's been another hit, and then finally it's like the straw that breaks the camel's back is what causes them to just lose it. And that's when the parents are like, oh my God, what's going on? But I think that the value in this conversation
Absolutely.
is if we go back to day one, and it's like, oh, this is the child that never slept well. This is the child that was obstructing or having disordered sleeping from 2-3 years of age. They weren't falling apart yet, but they were having that, and then little by little the stress response comes, and then little by little the immune changes come, and then the tonsils get bigger, and then
there you go. And that's exactly the key, because it all plays in together. Because any one intervention isn't going to be effective unless you get to the root, the foundation. And sleep and breathing is the foundation. But so is nutrition, and so is lifestyle choices of just having daily physical activity, and the nutritional choices that you're making can also impact your sleep. So if you're able to incorporate daily exercise, walking, that actually promotes deep sleep. And if you're able to incorporate meditation and the environment that you're in, all these things can have an effect. And so what you want to do is you want to use everything that you can from all these different disciplines to optimize your sleep, your breathing, your nutrition, and your physical health to ultimately bring down that inflammation and promote more of a parasympathetic coherence.
Yeah. And that's part of the conversation that I'm trying to bring forth to the families.
That's wonderful.
That you really have to look at it from every angle. This isn't just about fixing one thing. It's about really understanding the whole child and all their elements. But at the same time, being the holistic integrative pediatrician, what has been really amazing to me is in some of the cases that I've seen, because the children are in such a state of fight and flight, they're in such a high stress response, trying to change their diet and changing them to the healthy vegetables or whatever else sometimes sinks the ship.
Right.
And why I've become a proponent of the surgeries is because I've seen in some cases when you can open up the airway, and we'll get into all of this people a little bit later, it just helps bring down the stress response. The kids are now a little bit more sane. Then you bring in the vegetables and everything else and then keep plugging away.
Because these kids are trying to survive through the night. And those fatty foods and those sugars, that's their fuel to get through. And if you remove their fuel, so what their body has learned to digest, then like you said, they're trying to compensate the best they can, and then they decompensate. So it's the best thing to do is just to catch it early, to nip it in the bud at the first signs of any issues of sleep or mouth breathing or nutritional issues, to address any major threats, whether it's through surgery or through therapy or through diet changes or whatever it is, and then to just kind of maintain it, making sure that we have good foundations of sleep, breathing, diet, physical activity, nutrition. It all kind of comes together, and they're actually more related. That's why I love the kind of work that you do. You call it the holistic kids with a W, because it's the whole kid that you're looking at.
You have to.
And that's what you really have to do. You have to look at the whole kid, the whole picture. Not just one segment or one corner and get pigeonholed into thinking that there's a magic bullet that's going to...
There is no magic bullet. And I think part of it is also there is no one right thing for any one child. What works well for one kid is a complete failure for another. And by understanding your child, by understanding the underpinnings of what drives their physiology, their health, we can then say, okay, this child needs this child needs this child needs to have their tonsils taken out, this child needs to have this, and we'll talk about that in a second. But I want to touch on one other thing, because I found this one really interesting study that was talking about how in the more severe cases of airway obstruction, and Dr. Zaghi is going to go through all of this in more detail in just a little bit, but in the cases of more severe airway obstruction, apparently there are changes in the limbic system, in the amygdala, in the hippocampus. So these children actually have physiological, possibly even structural changes in that part of the brain. And this to me is really interesting, because when I read this study, it kind of blew my mind for a second, because what I see in these kids is they have trouble regulating their emotions, they have trouble regulating anger, they are just completely like in a chaotic state physiologically at the central nervous system, a lot of these kids can't retain any memory. So they're ADHD, they're not learning, they have learning disorders of whatever sort that are labeled to them. And when I read this one study, all of a sudden it's like, oh my God, if the limbic system and some of these deep elements of the brain are not functioning well, or in some cases, I guess structurally are actually becoming abnormal because of sleep, well, holy cow, in one type of children, it may be only 5% of the population we're talking about, but that means that 5 or 10 out of 100 families, actually this is very applicable to. So how do you see that picture? Because it blew my mind. It blew my mind.
Absolutely, absolutely. And so when you're talking about the way a child functions and the brain and development, you're looking at it from two perspectives. One is the hardware, which is the actual material of the brain, and the second is the software and how it runs. And so the kids that are in your practice, their brains are undergoing active development, not only from a hardware perspective, but also from a wiring of which neurons are connected to which neurons and the synaptic connections between them. And so what can happen in some cases with very severe sleep apnea is that they actually don't get enough oxygen, and they're causing irreversible damage to the hardware of the brain. So that those structures that you're talking about can no longer perform their job, and there are systematic errors in the structure of the brain. So that's what you see more often in the very severe cases of apnea, which happens to be much less common. So the severe sleep apnea is like 1 to 2%.
Okay.
What's more common that affects anywhere from 3 to 8% in the snoring population, or up to 25% in the mouth breathing and upper air resistance population.
Wow. 25%
of children may have mouth breathing.
Wow.
And that mouth breathing kind of perpetuates the inflammatory cycle and can affect their quality of sleep. And so when you're interfering with the quality of the sleep, what you're doing is you're affecting the way that the software is processed and developed and running. And fortunately, those are things that are reversible. So that you can kind of catch up. If you identify it early, you can get them into good sleep, and you can undo and reverse and help promote better learning and memory. And so that's again why we're talking. We want to catch the problem when it's just mouth breathing, or when it's just snoring, or when it's just restless sleep, before it's apnea, where they're losing oxygen and having mini strokes to the brain that are causing this irreversible brain damage.
That's scary.
Yeah.
That's really scary. So it's entirely possible that if families became really aware of the mouth breathing and kind of intervene early on, and I think in working with you and some of the other people in the community, I've just become now so aware that as soon as I see a kid mouth breathing, it's like, okay, how often are they mouth breathing? Are they mouth breathing all the time? And I've now become smarter to actually jump on that before it turns into these ugly things.
Absolutely, and the analogy that we use is smoke and fire, and so the mouth breathing is the first sign of smoke that something might be wrong. Mouth breathing is very common. 25 or up to 50% of the population, if they have a cold, they're congested, it's temporary, and you don't want to jump on it too aggressively and get too worked up about it, but it is a sign of smoke, and so you want to monitor it, and you want to identify it and take measures to minimize that smoke and even eliminate it. Because if you don't keep an eye on it and you just say it's normal, it's no problem, the next thing you know, you're down this cascade and you're dealing with a fire that's out of control. And the fire is going to leave injury and repercussions no matter how you put it up.
Gotcha. And that's when the really hardcore...
That's where the hardcore things...
surgeries and whatever else become necessary. Well, why don't we have you show us what disordered sleep and disordered breathing looks like, because you have some really wonderful visuals that I think will be very helpful for our audience.
I would love to.
Okay, great.
So we both love working with kids, and kids are so cute. But it's funny, if you look at this video that's available on YouTube, it's titled Cute Baby Snoring. You just want to ask yourself how familiar this is. Because really, this video shouldn't be titled Cute Snoring Baby. Rather, it should be called Concerning Snoring Baby. And the reason for that is that when you're breathing, you should be breathing through your nose, down your throat, with your lips together and your tongue up on the roof of the mouth. Now, if you have an airway obstruction of some kind, what can happen is that the mouth will fall open, and when the mouth is open, the tongue will take a down position, and actually block and narrow the breathing passage. So as air comes through, that air is going to vibrate and give you the sound of the noisy breathing or the snoring. Now what can happen as this problem progresses and as the tongue relaxes more, or you have narrowing of the airway due to inflammation of the tonsils or restrictions of the jaw, is that the throat can actually close up. And when the throat closes up, that's when you get obstructive sleep apnea with oxygen loss that can cause a lot of the harmful effects that we talked about. So what does sleep apnea look like in kids? Actual apnea means that these kids are not breathing well. So what does sleep apnea look like in kids? This is what it looks like. And so sleep apnea means cessation of breath. So as we're seeing in this video, this little girl actually holds her breath. She's not breathing. She's not breathing. And there's the recovery breath. And this kid right here, you can see he's trying to breathe. He has retraction in his chest. He's moving side to side to try to open up his airway all throughout the night. And so what can happen when you have these problems is it can really affect all aspects of your health and well-being and many of the things that we touched on. But it's not only about sleep apnea, it's also about respiratory effort-related arousals. So what happens here is that you're coming to block up your throat, you're about to get narrow and have an obstruction, but the airway suddenly opens up as you wake up. And then you try to go into deeper sleep and it closes. But before it blocks up to cause snoring or apnea, you wake up again. And in this case, you get stuck in light sleep versus deep sleep. And this is not called sleep apnea. This is called respiratory effort-related arousal. And it's actually on the spectrum of sleep-disordered breathing. So let's take a look at this case. This kid has some noisy breathing, but he doesn't have any apneas. You can see that he's breathing. It's just a little noisy. I'm not sure you'd even consider it to be snoring. You certainly wouldn't consider it to be apnea because he's breathing the whole time. And he's not having any oxygen loss, but he's compensating. He's compensating, pulling his neck forward, keeping his mouth open, and he just has mouth breathing. And what that mouth breathing does, it causes dehydration. You're losing a lot of volume of water out into the air. It creates systemic inflammation, and it also causes low tongue posture that's going to lead to poor orofacial growth and development. And so we talked about earlier how these problems with sleep disorder breathing can cause mood issues with depression, and really it all starts with the mouth breathing. There's a domino effect here where the first sign really is a compensation of the mouth breathing. If it goes unchecked, that mouth breathing can lead to noisy breathing. The noisy breathing gets worse to snoring, and that gets worse to sleep apnea through this inflammatory pathway that we talked about. So that really reinforces the importance of early diagnosis and treatment. So let's take a look at a few cases. First of all, optimal breathing should be quiet. Shouldn't be noisy or audible at all. They should be breathing completely through their mouth with their lips closed and their tongue up in the mouth palate. So even this is not okay. Here's a little girl that we had before we treated her with myofunctional tongue-tie release. Open mouth breathing, lips apart, positional sleep. The mother says that she can never sleep comfortably on her back. And so after treatment, here's what she looks like. It's just quiet. It's just peaceful. And this is what sleeping should look like. Deep, restful sleep. And this is actually now a published case report. And so these are the kind of things that you want to consider. Is there any snoring or audible breathing, gasping for air, mouth breathing, lips apart, open posture, moving around a lot, sleeping in strange positions, waking up a lot throughout the night, having to get up to use the restroom, sweating, teeth grinding, extending the neck. And what you might see in some cases is this situation in which the tonsils are really large. And the way that we grade tonsils is from 1 through 4, depending on how much of the airway is occupied. And so in this case, the tonsils actually occupy almost 90% of the throat volume. And so we consider these to be grade 4 tonsils, and this is kind of the late stage of the situation. Cases like this are considered the fire, where it's a little bit too late and you just have to come out, remove those tonsils, and free the kid from the constant cycle of inflammation that they're experiencing. But there are other cases like this one, where the tonsils aren't that large. There's just a lot of teeth grinding and he's breaking through his enamel. And it's these cases that we consider to be the smoke. These cases of teeth grinding and mouth breathing and the subtle clues. Because if you can catch it when it's a smoke, you'll really prevent it from becoming a fire. And so we take a look at this case and we can see that this is the smoke example. And he's having some crooked teeth, a little bit of a tongue thrust, potential posterior tongue tie here. The tonsils are starting to enlarge, and so we really see that it's a multifactorial issue that involves the tonsils, the tongue, and the teeth, and that's why we really have to work together when it becomes an airway issue with our medical and dental colleagues. Here's a great book that I recommended, Share More, Sleep Right Kids. If your kid's having trouble sleeping, it can be for a variety of reasons. It could be because of sleep apnea reasons, or can be because of other reasons. And this book will help you navigate some kind of tips and tools that you can use. Whenever I see a patient, I screen them for sleep and breathing issues with this questionnaire. And if the child is snoring, stop breathing, waking with a snarl, sleeping in odd positions, head extended back, grinding their teeth, this is concerning. And so myself as an ENT, I can intervene in these cases, but really it takes a team, a multidisciplinary team, because it's not just one simple issue, and that's why I'm privileged to work with you, Dr. K, in helping these kids thrive and do better. Here's another case to mention. He has a crossbite, so the dentist might pick up on some facial asymmetry. And so you might ask, why does he have this crossbite? And so a lot of times what it is kids who only sleep on one side, the positional sleep to open up their airway, actually will shift their jaw off to the other side. Then what happens is their teeth don't meet on this side, only meets on this side, so they're chewing on this side and their face grows asymmetrically. So you can see how a simple thing like sleeping on your side with your mouth open can really affect the way that your face develops. But it's not just that. He also is starting to develop large tonsils. And if you look there, he also has a tongue tie there. So the tongue tie is when you can't get the tongue up more than 50% of the way. And here we clearly see that he has this tongue tie that's affecting his ability to get his tongue up to the roof of the mouth. The other issue is that he's not growing appropriately. He's only 10 percentile for weight and less than 25 percentile for height. And so that suggests that he's not getting enough deep sleep, because it's during deep sleep that you release growth hormone that will allow you to grow and develop. And when you're getting into that deep sleep, you're going to prevent the elevation of cortisol, stress hormone, that's going to have a really bad effect, like we were talking about, on all aspects of your health and quality of life. It also, if you're not getting deep sleep, you're also losing that parasympathetic tone, and you're more in of a fight or flight response. The last thing that I'll mention is that it's not only sleep disruptions, but mouth breathing in and of itself can have an impact on the release of growth hormone. So, sleep disordered breathing is really common. Any kind of sleep disruption can stimulate cortisol, diminish parasympathetic activity, and interfere with the release of growth hormone and impair immune function.
So that was amazing what you showed us about the tonsils and airway and all the weird things that kids do to basically make up for problems with the breathing. Now, I've also been humbled a lot by learning about tongue ties and the palate and all of these subtle things that people really have no awareness, that I had no awareness. And I'm the holistic pediatrician that's had a bunch of training. So I would love for you to talk a little bit about how do you see tongue ties impacting things? And, first of all, what are tongue ties? Because I think there's a lot of people that don't even know about it. And maybe, I know that you and I have chatted in the past about the epidemic of tongue ties that we're seeing in some of the newborns.
Yeah, right. So a lot of times when you hear about tongue tie, you hear it in the context of breastfeeding, difficulty with latching and nursing issues. And the other time you might hear about tongue ties in kids who have difficulty with either speech or swallow issues. But what we've learned over the past few years, and thanks to the work of Dr. Guilleminault out of Stanford, is that tongue tie may actually be one kind or one cause of sleep disordered breathing, especially in kids.
Wow.
And it really may be one of the first things that kind of sets off a cascade of events that results in sleep disordered breathing.
Wow.
And so we saw some cases of enlarged tonsils, and there are a lot of different things that can cause enlarged tonsils. You can have environmental allergies. You can have sensitivities to dairy or to gluten. You can catch a virus. You can have recurrent throat infections that are causing tonsil hypertrophy. But one other thing that can cause large tonsils is actually mouth breathing. And so the way that tongue tie interfaces with mouth breathing is that the tongue needs to be, when you're nose breathing, the tongue is up in the roof of the mouth. When your tongue is up in the roof of the mouth, as I showed in some of the slides, you can't breathe through your mouth. It's impossible because the tongue is blocking it. And you become a more efficient nasal breather by having your tongue up. And the more nasal breathing that you're doing, you develop nitric oxide in the sinuses, and that acts like a vasodilator for your nose and for your lungs. So it perpetuates nasal breathing.
Wow.
So the more you breathe through your nose, the more you will breathe through your nose. But the more you breathe through your mouth, the more you're going to breathe through your mouth. Yeah. And so what happens is when you're a mouth breather, either because of tongue tie issues that force you to be in a low tongue position, because you can't get the tongue up because the tongue is held down, what happens is that this affects the way the teeth develop. Because when the tongue is held down, imagine that you have a muscle that's held down, that muscle is going to undergo atrophy, and it's going to get weak, and it's not going to want to be in that position. It's going to be in a down position. And if it's in a down position, it's not going to be effective in helping the teeth develop nice and broad. Instead, you get crooked teeth. And now when you have crooked and crowded teeth, there are two options. Some orthodontists may choose to pull out the teeth so it all looks straight, which we don't really advise in the airway. Or you can actually have expansion, maxillary expansion, to widen the skeletal framework for the airway.
Wow.
And there are other things as well, like myofunctional therapy that works on strengthening that tongue muscle.
Basically working it out.
Working it out. So giving it back that tone and strength, teaching it to be in the roof of the mouth, teaching the kids to be nose breathers. And then the way that tongue tie comes in is that sometimes no matter what you do, the tongue won't go up because it's physically tied down to the floor of mouth. And when it's physically tied down to the floor of mouth, you have to strain to get it up, and it's not comfortable. So that's where the release comes into play, the lengthening of the tongue, so that it actually can get up and do the functions that it does.
Wow. So catching the tongue tie as early as you possibly can, especially if you're starting to see signs of disordered breathing, is pretty paramount. Yeah,
so it's one of the things that you guys should definitely look for, is to look for signs of tongue tie, but not only tongue tie, it's also low tongue posture, just the tongue being in a down position. Kids should be able to lift their tongue up. And I don't want people to think that it's just about tongue ties, just get the tongue tie clipped. It's really not. The real issue is getting the tongue up in the roof of the mouth. And getting the tongue up in the roof of the mouth, what we do in my practice is we always start kids first in therapy, myofunctional therapy, tongue exercises, to see maybe with just a little bit of help, some physical therapy, they can get their tongue up just without surgery. And you only kind of introduce the surgical component if you think that's going to help them get their tongue up. Yeah. Because ultimately it's not only tongue ties that cause low tongue posture. We were talking earlier about some kids with low tone due to other issues, some metabolic issues or mitochondrial issues. And in those cases, you have to support them with nutrition and the tongue physical therapy. And you don't even need to have a tongue tie release performed.
Yeah. You know, I so appreciate you saying this, because I have to be honest, when I first heard of you, I was like, okay, is he one of those surgeons that just does surgery on everyone? And then to my surprise, when I sent you some patients, you're like, no, they don't need surgery, do myofunctional therapy. I'm like, wow, no, he really has a holistic approach. And I so appreciate that. I think that, you know, the way you bring this entire picture to the population, and this is why I want our audience to hear of your wisdom and all your experience, because, you know, I so appreciate that you're looking at all of these things and you're not just jumping to clip every tongue tie.
Right, yeah. So we're not looking to do surgery. I'm looking to help the kids do better, right? So you want them to come back for follow-up, whatever they did, and for the parents to tell you, he's sleeping better, he doesn't snore anymore, he's growing, he's doing better in school, he's nicer, he's making friends, he said I love you.
Oh.
That's what you want to hear.
Yeah.
And however they get there, and there's no point in jumping to a surgery, creating trauma and scar tissue and things like that, and not getting that result. That's not meaningful to me as a provider or clinician. You want the parent to come back and say, Johnny's doing great. Like, I'm really happy. You can just see it in some of these parents. You don't even have to ask. They just come in with a smile. They're just so happy. Kids speaking better, doing better in school, eating better, not as much of a picky eater, and that's it. That's the whole story.
It makes the world of difference, doesn't it?
It does.
Well, I'm curious about what you touched on with the low tone, because unexpectedly, I've had a few cases where I was actually helping other families, and it was feeding issues, and it turns out that familially we actually have a mitochondriopathy. So I was the kid that never crawled. It took me like 15-16 months before I walked, and sure enough, my daughter had the same pattern. So when I started pumping her full of CoQ10 and carnitine and some supplements, all of a sudden her muscle tone went up, and she's actually helped me become very aware of these things, because for me it's a very personal discussion. But in working with some families where the baby is completely floppy, it's the 9-month-old that's still having trouble rolling over. I've had 2 cases where we supplemented the child also with CoQ10 through the mom, or in one case directly, and then all of a sudden this baby that wasn't feeding started feeding, which had to do with the tongue tone and so forth. And can you elaborate on just how that works? Because the tongue is a muscle. Like, our entire mouth is basically surrounded by muscles. So if these muscles are weak, so we touched on the ties where it's tied down. But if we also have kiddos, and I have to say, in this population of kiddos that have the severe behavioral issues, even though we don't have the studies yet, I'm willing to bet that at least 30% of them have some kind of subtle mitochondriopathy, because they're the kids that are floppy, they have low core strength. I mean, these are the things that the OTs and PTs are seeing. They're the kids that tire out easily, they're the kids that would prefer not to go play with other kids, and they just want to sit and play quietly.
Wow.
These are all kids that have some form of subtle mitochondriopathy.
Absolutely, and it's great to have an awareness of the complexity of the metabolic pathways, because if your muscles can't function appropriately, you're going to see all those sequelae. I'm glad you brought up the mitochondrial myopathies, but I also wanted to introduce to the audience the methyl tetrahydrofolate reductase deficiency. So this is called MTFHR, and it's actually more common than you might think or might realize. And so what this does is it affects the ability of an individual to metabolize B12 and folic acid. And so these are essential things that kind of play into that metabolism mitochondrial pathway. It's just one more element that they are not, they eat the folic acid, the B12, but they're not able to absorb it and utilize it.
Right.
And that can also perpetuate a lot of these things that we're seeing in terms of the mitochondrial dysfunction, the muscle dysfunction, the fatigue that we're seeing in our kids. So it's really, really complex, and we need more individuals like yourself who are willing to read and learn and to look into uncharted territory to figure out what's happening in each case.
Well, speaking of the MTHFR, we had talked about this before, because I know in some circles in the holistic community, people are hell-bent that MTHFR is the sole cause or the primary cause of the tongue ties. And I know that I have reservations about that. And I think when we talked about it, we talked about how complex tongue ties are. And we can't make simple associations of, you have MTHFR, you'll get tongue tie.
No, absolutely. And I think that's the one key point is to put out there that these issues are very complex, interdigitated network of issues that are going on. And so while MTFHR is one contributing factor, there's also genetic factors and epigenetic factors that also go into the presence of those issues or absence. But I think if anyone's looking for a one-to-one connection, I think that's going to be a little bit challenging, because it's very, very complex.
Absolutely. So, I'd love to learn from your perspective. Let's say there's a theoretical, and if my guess is right, we've got the 30% of these kids that have a mitochondriopathy. So, and if it wasn't for my daughter, I probably wouldn't be as attuned to this as I am now. And I can say for sure that the conventional pediatric community just hasn't been made aware of these things. And I've sent some of these kids to geneticists that do mitochondrial things, and they were looking for the catastrophe, Lee syndrome things where the kids are dying, and everything outside of that they call normal, which is, I think, where a lot of our families are stuck, because they don't know who to go to. They've been told like there's nothing wrong with their kid, and they're like, no, there's something wrong with my kid. They're losing their mind. So let's say there's the theoretical, you've got the baby that didn't roll over, has low core strength, low tone, and with that they probably have low tongue tone because some of these kids also have difficulty feeding, right? That could potentially set off the cascade, right?
It certainly can. It certainly can. And so, like you're saying, if you have that low tongue tone, the tongue isn't going to be up in the roof of the mouth. It's slowly going to lose more and more and more tone, flop back to block up the airway. So they're going to have to sleep on their side, open their mouth in order to compensate for breathing. And when they're doing that, then they get dental crowding issues, they get large tonsils, and it certainly sets off the cascade. But especially in those cases, it's important to realize that in those cases, it may or may not be a tongue tie issue that's causing the low tone. Rather, it's the mitochondrial issue. And so you have to address that either medically, like you're describing with the supplementation of the coenzyme Q10 and the other medicine that you mentioned, or in addition to that, you can do occupational therapy for these kids. There's a lot of great occupational therapists out there with different exercises and regimens to help improve the sensory awareness of the tongue. Diane Barr has a wonderful book on oral motor development, and she introduces different tools that families can get from either Talk Tools or ARC Therapeutics, in which what they're doing is they're stimulating the oral cavity complex and helping it optimize. So just like you have any weak muscle, there are exercises and things you can do that, despite the limitation, you're still going to kind of do the best that you can. To in your situation, right?
Great. Well, would you mind showing us what tongue ties look like, the oral crowding that you're describing? I think visually, if people can see what all of this is like, that would be really invaluable.
I would love to.
Great.
When we're talking about tongue ties, we're talking about an attachment between the tongue and the floor of the mouth, such that the tongue is physically tied to the floor of the mouth. Some cases of tongue tie here are very obvious here, where the front of the tongue, it just can't get up. But there are other cases where the front of the tongue can get up, but the back of the tongue cannot get up. And these are the cases of the posterior tongue tie. And these posterior tongue ties may not be obvious at first glance because the kids can stick out their tongue over their teeth. It's just that they can't lift up their tongue. And that's really what we want to see. There are different ways of measuring for tongue ties, and one of the most common that most ENTs and primary doctors use is the Kotlow-free tongue measurement. But this is really only looking at the anterior tongue tie by making sure that you have enough free tongue length such that you can protrude your tongue. But what we've learned is that you might have cases like this that are definitely tongue-tied anteriorly, but you might have cases like this one where the front of the tongue is getting up, but it's the back of the tongue that has difficulty getting up. And when it's the back of the tongue that's not able to get up, that's what we call a posterior tongue tie. And so it's to assess for this, what we do is we assess whether the tongue can lift up, not out, but up. So we measure the maximum mouth opening, and then we see how far up does the tongue get relative to the mouth opening. In this example, the tongue is able to get up 76% of the mouth opening, and that's pretty good. So we consider it to be a tongue tie when the tongue cannot lift up more than 50% of mouth opening. And so here are some examples. These are adult patients in which the mouth opening here is measured at 58 millimeters, and the tongue is getting up just shy of 28 millimeters. And so in this case, this would be considered a grade 3 tongue tie. But it's not only about the front of the tongue getting up, it's about the back of the tongue getting up. And in this example, you can see that because of this attachment point, they're having difficulty getting up the back of the tongue. And so that's a very severe tongue tie, and that's where the release comes into play. And so if you do have one of these severe tongue ties, we've learned in our studies that it can actually affect the way that the teeth develop. And so if you have a tongue tie like this or like this, where the tongue can't lift up, it can cause problems with dental crowding. And then what happens is you have to evaluate them for orthodontics. And there's really two ways of doing this. One is to go ahead and pull out teeth in order to make room for all the teeth and to contract the airway. And this is really the last thing you want to do, because you already have an airway issue, and by contracting, you're taking up the space in the mouth for the tongue. You're making the airway even smaller. That's not what we want to do. Rather, we want to work with our dental colleagues to expand the palate, make these wider, so there's enough room for the tongue, and so the tongue can come out of the airway. And so here's an example of a palate expander, which is put in for maybe 3 to 6 months, sometimes longer. And it physically widens the jaw to make room for the teeth and for the tongue. There are a lot of different ways of doing these treatments, and you should talk to your pediatric dentist about the best way of doing that. The natural position for the tongue is up in the roof of the mouth. When the tongue is up in the roof of the mouth, you'll be able to breathe through your nose and down the throat unobstructed. But if the tongue is down, either because of tongue tie issues or because of low tone issues, what happens is that the tongue is actually blocking the airway, and this is going to cause your snoring, open mouth breathing, and noisy breathing issues. Again, the natural position of the tongue is up. When the tongue is up, you won't be able to breathe through your mouth. You'll have to breathe through your nose. And this is what you want to see in your babies. You want to see the tongue go up. From front to back, the whole tongue go up. And so if the front of the tongue is held down, that's an anterior tongue tie. But if the back of the tongue doesn't go up, that would be a posterior tongue tie. So here's an example from Dr. Larry Kotlow, who's an expert tongue tie specialist, demonstrating a thick posterior tongue tie band here. He's trying to lift up the tongue with his 2 fingers. He's trying to lift it up. And you see that white band there? That white band is actually holding down the tongue. And so that's what you're looking for when you're looking for tongue tie. You're looking to assess whether there are structures inside the mouth that are physically preventing the tongue from getting up.
So thank you for sharing all of that invaluable information. Now you touched on some of the occupational therapists and what they can do in the book. So from your perspective, how would parents navigate this water? So now let's say we've had this discussion, they've taken all of this information in, and now they're like, oh my God, my kid is the kid that he's describing. They had this issue, and that they did the mouth breathing and so forth. So now that parents have potentially come onto the conversation, they are realizing that their kid is having an issue. How do they navigate the waters? Because I've seen a lot of ENTs dismiss this. I've seen pediatricians dismiss these issues. So as a parent, how can you help them figure out where to go? Do they start off with a speech therapist, an occupational therapist, pediatrician? So what is the best way to go now that they know some of
what the checkpoints are? Yeah. So really it's about gaining access to the right network of providers who understand this. So there are a lot of different books that parents can read. There's for sleep issues, there's a wonderful book by Sharon Moore, Sleep Wreck Kids, which will give excellent tips and recommendations for specifically what they can do for different causes of problems with sleeping. So airway is one reason they can't sleep well, but there's also sleep hygiene issues, and that's a terrific book geared directly towards parents and families on what they can do to help improve sleep.
Great.
If they're afraid that it's a tongue tie issue, there's a wonderful book by Richard Baxter. It's called Tongue Tied, and they can read more about that.
Fantastic. And we'll link to all of those in our references.
And it's for oral motor feeding and development. Diane Barr has a wonderful book. And I think those are like a few good places to start. Those textbooks will those little parent guides will kind of give you directions for next steps. Beyond that, the next step would be to get inside a physician network. So as you know, certain doctors in certain communities see more to eye with each other, and there are certain pediatricians that we prefer to work with, or certain speech therapists or dentists who really understand the problem, and there are those who kind of don't really appreciate the gravity of the issue. So I'm giving courses and providing education to ENTs and dentists and doctors so they can kind of learn about this. But you're going to reach a broad audience, and so there are wonderful Facebook support groups that parents can go on and become members of and say, hey, is there anyone here in my community, whether it's a myofunctional therapist, a speech therapist, a dentist, an ENT, a pediatrician, doesn't matter what background they come from, as long as they're aware of airway and what's important. And a lot of continuing education out there available for providers who want to learn more about this topic.
Great.
So really it's just about education, working together, advancing the field together, getting the word out there, and doing the research, publications that are going to get more providers on board with this mission.
Beautiful, beautiful. And so maybe as a starting point, once the people have done this, like in the local communities, would you say speech therapists and occupational therapists may be a good kind of entry point because they are more attuned to these things if their pediatrician or ENT have been like, no, there isn't an issue?
Yeah, it really depends. So it really depends on their training and what they're allowed to do. Some speech therapists work in the school system, and those are specifically barred from diagnosing or mentioning the word tongue-tied.
Wow.
Because if they say your child is tongue-tied, and it gets diagnosed from the school is liable to pay for that treatment.
Wow, I didn't know that.
Yeah, so school-based speech therapists, you'll talk to them, they'll tell you, my hands are tied. If I see a problem with the tonsils or the tongue, the best I can do is tell or hint them, hey, talk to your doctor about this, talk to your pediatrician, maybe go see an ENT, or they might slip you the card of an ENT who really understands it. But that's the most that they can do if they want to keep their jobs.
Gotcha.
Yeah, so it really depends on finding the right person. I totally get that it's a little bit more challenging. But I think reaching out, our office is working on developing a network of doctors and therapists who understand this issue.
Beautiful.
Yeah, anyone who's trained in myofunctional therapy, if they just want to use that kind of buzzword, myofunctional therapy, whether it's a speech therapist or an occupational therapist, I will assure you that those providers will have at least some kind of continuing education in this airway issue. So just look out for that term.
And we'll certainly be providing you, a big reference list of all the resources we can, and possibly we can have someone from your team even help guide one of our groups, because we will have some support groups going.
Fantastic. We'd love to help support you guys any way we can.
Thank you. Well, thank you for sharing all of this. This has been so valuable, and I know our audience is going to love every piece of information you have shared and all the wisdom that you have, because you're one of a kind. And thank you for holding the space for everyone.
Oh, and so are you. And thank you for your passion and making this possible and volunteering your time and your efforts to getting this information out there. It's a real privilege to be one of your colleagues, and I'd love to volunteer myself anytime that you need some help or get the word out.
Thank you.
Thanks, Dr. Canary.
Thank you for watching, guys.